And hi, and welcome to Mindful. I'm delighted today to have my good friend and close colleague, Dr. Richard Mollica, join us. Dr. Mollica is a distinguished scholar at the William James College. He is a professor in the Harvard School of Medicine and affiliated with Massachusetts General Hospital. And he is the founder, 30 years plus, of the Harvard Program in Refugee Trauma. And today we're going to talk about a vitally important topic and a very sadly timely topic, which is the whole issue of refugees and refugee health and refugee mental health. Why don't we begin going back 30 plus years ago? You founded a very novel and innovative center, the Harvard Program in Refugee Trauma. What was the engine to drive you in this direction? And what was the impetus in the early work of the center?
Well, Dr. Berman, it's an honor to be here in this interview. Before I answer that question, I want to express my deep appreciation for the school and for the faculty and the young psychologists that work here. I mean, I am trained in neurology, epidemiology, trained as a medical doctor, psychiatrist, but I have to admit I have a very, very deep appreciation of the field of psychology for one very important reason. You know, psychologists listen to patients. They listen to traumatized people. The profession that epitomizes empathy and the holistic approach to the patient, you know. That's why I teach at the school, and that's why I love the students and the faculty here, you know. Now, to get into HPRT, because HPRT, the Harvard Program in Refugee Trauma, began as an experiment in December of 1981, and I was put in charge of the psychiatry service. Thousands of Indo-Chinese refugees were being screened and coming through the Bright Marine Public Health Center, and not a single one had ever been treated in psychiatry over the past 2 or 3 years. And I knew this would be the case because I was, my great mentor, Fritz Redlich, who was one of the great psychiatrists of the 20th century, professor, chairman, and dean at Yale Medical School. In 1958, he published what Hollingshead, Social Class and Mental Illness, that showed not only that poor people had a higher rate of mental illness, but also poor people got a different and probably an inferior treatment to upper middle class people, etc. And when I was at Yale, I did the follow-up to that. So it was the great age of social medicine. We were committed to making a difference in the community. So I said, hey, to Jim, let's open up a clinic here for the refugees. And just then in this note, because we have to be honest about what we call the courage of our ignorance, you know, the courage of not knowing anything, we started a clinic 1/2 day a week in a primary health care clinic in our building, seeing Indo-Chinese refugees, and the reality was the following. You know, at 5 years at Yale, I had 2 one-hour lectures on trauma. Never heard of torture. Never heard of the UN Declaration of Human Rights. Had no idea, didn't have a clue what a refugee was. Had never been, I wasn't in the Vietnam War, so I didn't go to Vietnam. I didn't know how to make a diagnosis in another culture. It goes on and on and on. I mean, we had, and also there was a general opinion at the time that people who had lived through extreme violence were not analyzable. In other words, that if you had had massive violence, you couldn't be analyzed in psychoanalysis, you know. And there was also another opinion widely believed that Asians didn't have depression, they had neurasthenia, that they primarily somaticized their depression, that they didn't meet in groups, they wouldn't tell you what was going on with them. And so basically, being a phenomenologist trained at Yale at the Divinity School, we put a bracket, you know, we took it, we said, okay, let's take every position in this field, put a parentheses around it, and say maybe true, maybe false. Maybe people with extreme violence can't be allies. Maybe Asians don't have depression but neurasthenia. Maybe people won't tell their story. We put brackets around this. Maybe you can't make a diagnosis in another culture. And so after the next 25 years, we discovered that almost all of those beliefs at that time were completely wrong. So we had to do the research and do the clinical care, do the research, do the training, do the qualitative and quantitative work, be in the field to create like a new science of refugee mental health. So I think our biggest contribution was in 1980s, we invented the Harvard Trauma Questionnaire. And the Harvard Trauma Questionnaire was the first questionnaire ever to ask traumatized people what was going on with them who had been through extreme violence.
Let's talk a little bit about applications from the HPRT team. So I know that you have done early work in Cambodia. I know you've done work in Italy, in Japan, in Cambodia, in Kosovo, in many, many settings. Could you briefly describe one or two programs so that our viewers will have some sense of what you do?
We first went to the Cambodian refugee camps in the early 1990s and spent 10 years working there and did some of our seminal work in Site 2, a camp called SITE, Site 2. And we did some of the groundbreaking work on the mental health impact on mass violence on refugees. We were the first one ever to define, show through data and through science what was the impact of extreme violence and refugee experience on Cambodian refugees. First time a study ever done. Our basic model has always been based on a number of basic principles. Principle number one, enter into the country through the mystery of health. Because this ultimately, the mystery of health in that society is responsible for the health and welfare of the general public. So unlike many NGOs, like in Haiti, for instance, we went through the mystery of health. Wherever we go through the mystery of health, now there's some problems with that, especially if the mystery of health is still abusing people. It's a complicated relationship. So we now have a project in Liberia where we work with the Carter Center, the World Bank, the Ministry of Health, and we're doing a very progressive, innovative project on health promotion for poor Liberian women, where Liberian women are taught how to be healthy in 8 domains, eight major domains that they care about, not that what we care about, what they care about: menstruation, foot care, sexually transmitted diseases. I could go through the whole list, And the women were trained to train other women. So you have a model of the community being trained who have no access to primary health care, have to rely on self-healing, who have a very high level of poor knowledge about health. 70% of them have been sexually abused, So we go in with the health promotion training, and then they train these 60 women we train, are training 240 other women. And then we're trying to build this into a project that links education and health to work. So if you increase the agency, the agency efficacy of people to be healthy, then we also believe that it reduces depression, reduces sexual transgressions because there's less transactional sex, and it goes on and on, that the high tide lifts all boats. In other words, health promotion lifts the person up to a more active environment where they feel healthy, they feel empowered to help their family, to help other women, and we're very excited about this model. So the bottom line is our model, whether we're in Cambodia, Peru, wherever, is what we call integrated holistic approach, and I could talk more about that around how we do that. We did that in other settings,
Thank you. I want to underscore that you are emphasizing some points that are key to your approach and are topics you and I have talked about at some
Yeah,
length.
definitely, right.
And one of these ideas that you talk about is that one and done helps the provider feel good, at least in a transitory way, but may not be an ongoing service to the community. So there's the importance of building relationships and then staying for the duration. And there's importance in looking at what's an effective, cost-effective way for a project to sustain.
Right.
And your Liberian example is an excellent one about how you're succeeding in building sustainability.
A principle in our group is listen to the people, find out what they really need, and don't come in with your idea from the outside and hit them with your idea. Yeah, really listen deeply. This is the listening part. Listen deeply to most women in Liberia that we interviewed in an assessment really cared a lot about menstruation issues, So we responded to that, saying, now, sitting here in Boston, how would I know that? You see, and also the partnership. The other thing, our principle is partnership and teamwork. Having a bicultural, bilingual partnership and teamwork is very difficult, and it takes a lot of skills. And like we say in our group, cultural friction in bicultural partnerships, international partnerships is normal, par for the course. But what we call rupture and repair, you have a problem, you repair it, you go to a higher level. So we're not afraid of cultural friction. We invite difficult discussions. We work closely with our partners. In every project we have, there's like we have a project in Lebanon building schools for Syrian children that they build themselves through the work of a brilliant Syrian Lebanese architect. The Lebanese involved in this project own this project. They're really a key partner in this project. And I think in the global world we live in today, you really have to have good intercultural partnership. And that's something you learn at a school like William James. I mean, this school is about how to run organizations and programs and teams where there's very close, not easy teamwork and partnerships. And I'm really big on teamwork and partnerships.
As I know you are.
Yeah.
We're coming towards the conclusion of this brief interview. I think a really fitting way to end is to continue what you just began in talking about William James. And let me help focus the question. I know that you care deeply about training the next generation of practitioners. Mm-hmm. I always hear you plan projects with saying, and I'm bringing these to early career people.
Yes.
So some of the graduates from our program in multicultural and global mental health have gone on to have a real impact in far afield. And I wonder if we could close with you mentioning some of the students that you've mentored and what they're doing.
Oh yeah. Well, we've had fantastic students here. The student narrative, which I love, is they're kind of insecure, but very idealistic. They're very idealistic. They're kind of insecure and really don't know where they're going. And through good teaching, good mentoring, good supervision, their idealism and their passion comes together, and they're doing quite extraordinary things. So I'm very proud of these young people, and they're like, this is our future. It's a joy. I mean, you get a lot out of mentoring young people, and I'm really happy to say not surprised that the young people really appreciate their elders. I'm thrilled about that. They like they love their elders, actually. I mean, there's a kind of natural synergism between the young people and their elders. That's all I can say. To me, it's been a joy,
Thank you so much for joining
Well,
us.
thank you for having me. It's such a great school. It's an honor to be here,
Thank you.